Question 1. A patient in cardiac arrest has received a total of 3 mg of epinephrine. Which of the following describes the appropriate next step regarding epinephrine administration? A. Increase the dose to 3 to 5 mg. B. Continue 1 mg 4/IO every 3 to 5 minutes. C. Switch to vasopressin 40 units 4/IO. D. Discontinue epinephrine if no response. Answer B. Continue 1 mg 4/IO every 3 to 5 minutes. This question tests your knowledge of the standard epinephrine dosing in cardiac arrest. The key phrase total of 3 mg indicates that the patient has received the typical single dose 3 times. The correct approach is to continue administering epinephrine 1 mg 4/IO every 3 to 5 minutes, as this is the standard, repeated dose during resuscitation until return of spontaneous circulation, ROSC, is achieved or the code is terminated. There is no guideline to increase the dose beyond 1 mg or switch to vasopressin as a routine next step once epinephrine has been started in this manner. Remember, consistent and timely administration of epinephrine is crucial during cardiac arrest. Question 2. Which medication is indicated for a patient experiencing symptomatic bradycardia after atropine has been administered and proved ineffective? A. Adenosine. B. Amiodarone. C. Dopamine. D. Lidocaine. Answer C. Dopamine. This question focuses on the management of symptomatic bradycardia, specifically when the initial treatment with atropine is insufficient. The key clue is after atropine has been administered and proved ineffective, which points to second-line agents. Dopamine infusion, or epinephrine infusion, is the correct choice in this scenario, as both are vasopressors that can increase heart rate and blood pressure by stimulating beta-adrenergic receptors. Adenosine is used for supraventricular tachycardias, amiodarone for ventricular arrhythmias, and lidocaine for ventricular arrhythmias, none of which are indicated for bradycardia. If atropine fails, think about starting a drip like dopamine to support the heart rate and perfusion. Question 3. What is the initial dose of adenosine for stable narrow complex tachycardia that is unresponsive to vagal maneuvers? A. 3 mg 4 push. B. 6 mg 4 push. C. 12 mg 4 push. D. 1 mg per kilogram 4 push. Answer B. 6 mg 4 push. This question assesses your knowledge of adenosine dosing for supraventricular tachycardia, SVT. The important keywords are initial dose, adenosine, and stable narrow complex tachycardia. The recommended initial dose of adenosine is 6 mg, administered as a rapid 4 push, followed by a flush. If the first dose is ineffective, a second dose of 12 mg can be given. Giving the correct initial dose promptly is essential for converting SVT back to a normal sinus rhythm. Question 4. A patient is in refractory ventricular fibrillation. After initial defibrillation and epinephrine, which antiarrhythmic medication is typically administered first? A. Lidocaine. B. Procainamide. C. Amiodarone. D. Sotalol. Answer C. Amiodarone. This question addresses the antiarrhythmic medications used in refractory ventricular fibrillation, VF, or pulseless ventricular tachycardia, private. The crucial phrase refractory ventricular fibrillation, after initial defibrillation and epinephrine, directs you to the first-line antiarrhythmic. Amiodarone is the preferred initial antiarrhythmic drug for these conditions in ACLS, typically given as a 300 mg 4/IO bolus. Lidocaine is an alternative if amiodarone is unavailable or contraindicated, but amiodarone is generally favored first. When the heart won't stop quivering, think amiodarone to help stabilize it. Question 5. What is the primary indication for magnesium sulfate in cardiac arrest? A. Symptomatic bradycardia. B. Pulseless electrical activity, PEA. C. Torsades de pointes. D. Asystole. Answer, C. Torsades de pointes. This question focuses on a specific indication for magnesium sulfate in the context of cardiac arrest. The key to answering this is knowing that magnesium sulfate is specifically indicated for polymorphic ventricular tachycardia, particularly torsades de pointes, which is a specific type of VT characterized by a twisting appearance on the ECG. While it can also be used for life-threatening arrhythmias due to hypomagnesemia, torsades de pointes is the most prominent indication in cardiac arrest algorithms. Remember, if you see torsades, think magnesium. Question 6. What is the recommended dose of atropine for symptomatic bradycardia? A. 0.25 mg 4. B. 0.5 mg 4. C. 1 mg 4. D. 3 mg 4. Answer, B. 0.5 mg 4. This question tests your knowledge of the appropriate dosing for atropine in symptomatic bradycardia. The keyword symptomatic bradycardia signals a need to increase heart rate. The recommended initial dose of atropine is 0.5 mg 4, which can be repeated every 3 to 5 minutes, up to a maximum total dose of 3 mg. Administering the correct dose helps to block the parasympathetic influence on the heart, thereby increasing heart rate. It's important to remember this dose to effectively manage a slow, symptomatic heartbeat. Question 7. After successful resuscitation from cardiac arrest, a patient develops stable wide complex tachycardia with a pulse. Which antiarrhythmic might be considered? A. Atropine. B. Epinephrine. C. Adenosine. D. Amiodarone. Answer, D. Amiodarone. This question explores the management of stable wide complex tachycardia with a pulse, especially in a post-arrest setting. The key phrase stable wide complex tachycardia with a pulse indicates that the patient is not immediately crashing and allows time for antiarrhythmic medication. Amiodarone is a common and appropriate choice for stable wide complex tachycardia, particularly if the rhythm is ventricular in origin, as it helps to suppress ventricular ectopy and stabilize the rhythm. Atropine is for bradycardia, epinephrine for cardiac arrest or severe hypotension, and adenosine for narrow complex SVT. Question 8. For a patient in cardiac arrest, what is the recommended intravenous/intraosseous dose of epinephrine? A. 0.1 mg. B. 0.5 mg. C. 1 mg. D. 2 mg. Answer, C. 1 mg. This question focuses on the standard dose of epinephrine during cardiac arrest. The keywords cardiac arrest and intravenous/intraosseous dose are direct cues. The recommended dose of epinephrine in cardiac arrest is 1 mg 4/IO, administered every 3 to 5 minutes. This consistent dosing is critical for attempting to achieve vasoconstriction and improve coronary and cerebral perfusion during CPR. Always remember this specific dose for cardiac arrest. Question 9. In the management of symptomatic bradycardia, if atropine is ineffective, what is the next drug that may be considered before transcutaneous pacing? A. Lidocaine infusion. B. Dopamine infusion. C. Adenosine bolus. D. Verapamil. Answer B. Dopamine infusion. This question tests the management algorithm for symptomatic bradycardia when atropine fails. The crucial phrase, if atropine is ineffective, guides you to second-line pharmacologic options. Both dopamine and epinephrine infusions are considered alternatives or adjunctive therapies to atropine for symptomatic bradycardia, typically before resorting to transcutaneous pacing if the patient is still unstable. Lidocaine, adenosine, and verapamil are not indicated for bradycardia. Question 10. A patient presents with acute pulmonary edema and severe hypertension. Which medication might be considered to reduce preload and afterload? A. Atropine. B. Epinephrine. C. Nitroglycerin. D. Dopamine. Answer C. Nitroglycerin. This question addresses the treatment of acute pulmonary edema with severe hypertension. The key descriptors, acute pulmonary edema and severe hypertension, combined with the need to reduce preload and afterload, point directly to vasodilators. Nitroglycerin is an excellent choice as it causes both venous dilation, reducing preload, and arterial dilation, reducing afterload, thereby easing the heart's workload and improving pulmonary congestion. Atropine is for bradycardia, epinephrine for arrest or shock, and dopamine for hypotension or bradycardia. Question 11. What is the maximum total dose of atropine that should be administered for symptomatic bradycardia? A. 1 mg. B. 2 mg. C. 3 mg. D. 6 mg. Answer C. 3 mg. This question specifically asks about the maximum total dose of atropine for symptomatic bradycardia. While the initial dose is 0, 5 mg, it can be repeated, but there's an important upper limit. The maximum cumulative dose of atropine is 3 mg. Exceeding this dose is generally not recommended as it rarely provides additional benefit and can potentially lead to adverse effects. Keeping this maximum in mind helps ensure safe and effective treatment. Question 12. A patient is experiencing ventricular tachycardia with a pulse. They are stable. Which medication would be appropriate for chemical cardioversion? A. Epinephrine. B. Adenosine. C. Amiodarone. D. Atropine. Answer C. Amiodarone. This question focuses on the pharmacologic treatment for stable ventricular tachycardia with a pulse. The key is ventricular tachycardia with a pulse and stable, indicating that immediate defibrillation is not needed and drugs can be used. Amiodarone is a primary antiarrhythmic agent used for both stable monomorphic and polymorphic ventricular tachycardia. Epinephrine is for cardiac arrest, adenosine is for SVT, and atropine is for bradycardia. Question 13. Which medication is contraindicated in patients with symptomatic bradycardia if a high-degree AV block, e.g., Mobitz 2 or third-degree AV block, is suspected? A. Epinephrine. B. Dopamine. C. Atropine. D. Norepinephrine. Answer C. Atropine. This question highlights an important contraindication for atropine in symptomatic bradycardia. The crucial clue is high-degree AV block, e.g., Mobitz 2 or third-degree AV block, is suspected. In these specific types of blocks, atropine is often ineffective because the conduction block is below the AV node, and may even worsen the block in some cases. In such situations, Transcutaneous pacing is usually the preferred initial intervention, and other chronotropic agents like dopamine or epinephrine infusions might be considered cautiously. Always be careful with atropine when the block is severe. Question 14. What is the typical initial infusion rate for dopamine in symptomatic bradycardia? A. 1 to 2 mcg/kg/min. B. 2 to 10 mcg/kg/min. C. 10 to 20 mcg/kg/min. D. 20 to 50 mcg/kg/min. Answer B. 2 to 10 mcg/kg/min. This question targets the specific infusion rate for dopamine when used for symptomatic bradycardia. The key is symptomatic bradycardia, which indicates the need for chronotropic and inotropic effects. The recommended initial infusion rate for dopamine is 2 to 10 mcg/kg/min, titrated to effect, which aims to increase heart rate and improve blood pressure. Rates above 10 micrograms per kilogram per minute primarily cause vasoconstriction, which may not be the main goal in bradycardia. Question 15. For a patient in pulseless electrical activity, PEA, what is the primary drug administered? A. Atropine. B. Adenosine. C. Amiodarone. D. Epinephrine. Answer D. Epinephrine. This question focuses on the primary drug for pulseless electrical activity, PEA. The keyword pulseless electrical activity signifies a non-shockable rhythm in cardiac arrest. Epinephrine is the primary drug given for PEA, and asystole, administered at 1 mg 4/IO every 3 to 5 minutes, because it helps to increase coronary and cerebral perfusion through its vasoconstrictive effects. The other drugs are indicated for specific arrhythmias or bradycardia. Question 16. What is the main action of epinephrine during cardiac arrest? A. Slows heart rate. B. Blocks calcium channels. C. Causes vasoconstriction. D. Suppresses ventricular ectopy. Answer C. Causes vasoconstriction. This question asks about the main action of epinephrine in the context of cardiac arrest. While epinephrine has multiple effects, the primary beneficial action during cardiac arrest is its alpha-adrenergic effect, which causes systemic vasoconstriction. This vasoconstriction increases aortic diastolic blood pressure, improving coronary and cerebral perfusion pressure, which is crucial for delivering oxygen to the heart and brain during CPR. It does not slow heart rate, block calcium channels, or directly suppress ventricular ectopy as its main goal in cardiac arrest. Question 17. After a successful resuscitation, a patient develops stable narrow-complex tachycardia. Vagal maneuvers are attempted and fail. What medication is the next best option? A. Epinephrine. B. Lidocaine. C. Adenosine. D. Norepinephrine. Answer C. Adenosine. This question describes a common scenario for adenosine use. The key terms are stable narrow-complex tachycardia and vagal maneuvers attempted and fail. Adenosine is the first-line pharmacologic agent for stable narrow-complex tachycardias, typically SVT, that do not respond to vagal maneuvers. It temporarily blocks AV nodal conduction, allowing for diagnosis or termination of the rhythm. Epinephrine and norepinephrine are vasopressors, and lidocaine is an antiarrhythmic for ventricular rhythms. Question 18. What is the recommended second dose of adenosine if the initial dose is ineffective for stable narrow-complex tachycardia? A. 3 mg for push. B. 6 mg for push. C. 12 mg for push. D. 1 mg per kilogram for push. Answer: C. 12 mg for push. This question specifically asks about the second dose of adenosine. The keywords are second dose, adenosine, and ineffective for stable narrow-complex tachycardia. If the initial 6 mg dose of adenosine fails to convert the rhythm, the recommended second dose is 12 mg, also given as a rapid 4-push. It's crucial to follow the dosing sequence for effective treatment of SVT. Question 19. A patient in cardiac arrest has received 2 doses of epinephrine. What antiarrhythmic medication might be considered if they are in refractory ventricular fibrillation? A. Diltiazem. B. Verapamil. C. Amiodarone. D. Metoprolol. Answer: C. Amiodarone. This question describes the scenario for administering an antiarrhythmic in refractory ventricular fibrillation, VF. The key phrase refractory ventricular fibrillation after epinephrine indicates the need for a drug to help stabilize the heart's electrical activity. Amiodarone is the preferred antiarrhythmic drug for persistent VF or pulseless VT that is unresponsive to defibrillation and epinephrine. Diltiazem, verapamil, and metoprolol are not used in cardiac arrest for VF. Question 20. What is the primary role of amiodarone in ACLS algorithms? A. To treat symptomatic bradycardia. B. To increase blood pressure in shock. C. To treat refractory ventricular arrhythmias. D. To convert supraventricular tachycardia. Answer: C. To treat refractory ventricular arrhythmias. This question asks about the primary role of amiodarone in ACLS. The main indication for amiodarone in cardiac arrest algorithms is the treatment of refractory ventricular fibrillation, VF, or pulseless ventricular tachycardia, private, meaning rhythms that persist despite defibrillation and epinephrine. It's also used for stable ventricular tachycardia with a pulse. It does not treat bradycardia, increase blood pressure primarily, or convert SVT as its primary role. Question 21. What is the initial intravenous/intraosseous dose of amiodarone for ventricular fibrillation/pulseless ventricular tachycardia? A. 150 mg. B. 300 mg. C. 450 mg. D. 5 mg per kilogram. Answer: B. 300 mg. This question specifically asks about the initial dose of amiodarone for cardiac arrest due to VF/private. The keywords are initial intravenous/intraosseous dose, amiodarone, and ventricular fibrillation/pulseless ventricular tachycardia. The recommended initial bolus dose of amiodarone in this setting is 300 mg 4/IO. This large initial dose aims to rapidly load the patient with the antiarrhythmic to suppress the life-threatening rhythm. Question 22. If the initial dose of amiodarone is ineffective for refractory ventricular fibrillation/pulseless ventricular tachycardia, what is the recommended second dose? A. 75 mg 4/IO. B. 150 mg 4/IO. C. 300 mg 4/IO. D. 450 mg 4/IO. Answer: B. 150 mg 4/IO. This question builds on the previous one, asking about the second dose of amiodarone. The critical phrases are initial dose of amiodarone is ineffective and refractory ventricular fibrillation/pulseless ventricular tachycardia. If the initial 300 mg bolus of amiodarone does not resolve the VF/private, a second dose of 150 mg 4/IO can be administered. This sequential dosing is crucial for managing persistent ventricular arrhythmias in cardiac arrest. Question 23. Which drug is considered an alternative to amiodarone for refractory ventricular fibrillation/pulseless ventricular tachycardia? A. Diltiazem. B. Lidocaine. C. Verapamil. D. Procainamide. Answer: B. Lidocaine. This question asks for an alternative antiarrhythmic drug to amiodarone in cardiac arrest. The key terms are alternative to amiodarone and refractory ventricular fibrillation/pulseless ventricular tachycardia. Lidocaine is the primary alternative antiarrhythmic drug in the ACLS algorithm if amiodarone is unavailable, contraindicated, or ineffective. The initial dose is 1:1, 5 mg/kg 4/IO. Diltiazem and verapamil are calcium channel blockers, and procainamide is a less commonly used alternative in the acute cardiac arrest setting. Question 24. What is the initial intravenous/intraosseous dose of lidocaine for ventricular fibrillation/pulseless ventricular tachycardia, if used as an alternative to amiodarone? A. 0, 5-0, 75 mg/kg. B. 1:1, 5 mg/kg. C. 2:2, 5 mg/kg. D. 3 mg per kilogram. Answer: B. 1:1, 5 mg/kg. This question tests your knowledge of lidocaine dosing in cardiac arrest. The keywords are initial intravenous/intraosseous dose, lidocaine, and ventricular fibrillation/pulseless ventricular tachycardia, if used as an alternative. The recommended initial dose of lidocaine is 1:1, 5 mg/kg 4/IO. This dose is given as a bolus to quickly achieve therapeutic levels to suppress the ventricular arrhythmia. Question 25. What is the purpose of administering sodium bicarbonate during cardiac arrest? A. Routine use for all cardiac arrests. B. To correct acidosis in specific situations. C. To increase the heart rate. D. To decrease blood pressure. Answer: B. To correct acidosis in specific situations. This question addresses the appropriate use of sodium bicarbonate in cardiac arrest. The keyword purpose focuses on its indication. Sodium bicarbonate is not routinely recommended during cardiac arrest. It is considered only in specific situations, such as known pre-existing metabolic acidosis, hyperkalemia, or tricyclic antidepressant overdose, where correcting severe acidosis may be beneficial. It does not routinely increase heart rate or decrease blood pressure. Always remember that its use is targeted, not universal. Question 26. What is the recommended intravenous/intraosseous dose of sodium bicarbonate when indicated in cardiac arrest? A. 0, 5 milliequivalent/kg. B. 1 milliequivalent/kg. C. 2 milliequivalent/kg. D. 50 milliequivalent fixed dose. Answer: B. 1 milliequivalent/kg. This question asks about the specific dose of sodium bicarbonate when it is indicated for cardiac arrest. The keywords are recommended intravenous/intraosseous dose and sodium bicarbonate. When used, the recommended dose is 1 milliequivalent/kg 4/IO. It's important to remember that sodium bicarbonate is not a routine drug in cardiac arrest, but when needed for specific conditions like severe metabolic acidosis, this is the appropriate dose. Question 27. When considering calcium chloride in cardiac arrest, which condition is a specific indication for its use? A. Asystole. B. Ventricular fibrillation. C. Hyperkalemia. D. Hypoglycemia. Answer: C. Hyperkalemia. This question focuses on a specific indication for calcium chloride in cardiac arrest. The keyword specific indication is crucial here. Calcium chloride is not routinely used in cardiac arrest, however, it is specifically indicated for known or suspected hyperkalemia, high potassium, calcium channel blocker overdose, or magnesium toxicity, as it helps to stabilize the cardiac cell membrane. Hyperkalemia is a life-threatening cause of cardiac arrest where calcium can be very beneficial. Question 28. A patient is in cardiac arrest due to a suspected tricyclic antidepressant overdose. Which medication might be beneficial? A. Atropine. B. Magnesium sulfate. C. Sodium bicarbonate. D. Calcium chloride. Answer: C. Sodium bicarbonate. This question presents a specific scenario of cardiac arrest due to tricyclic antidepressant, TCA, overdose. The key phrase, tricyclic antidepressant overdose, is a strong clue. Sodium bicarbonate is indicated in TCA overdose because it helps to alkalinize the blood, which reduces the binding of TCAs to myocardial sodium channels, thereby mitigating their cardiotoxic effects and potentially improving conduction abnormalities and hypotension. It's a targeted treatment for this specific toxicologic emergency. Question 29. What effect does epinephrine have on the coronary arteries during cardiac arrest? A. Vasodilation. B. Vasoconstriction. C. No effect. D. Directly improves contractility without affecting vessels. Answer: B. Vasoconstriction. This question asks about the specific effect of epinephrine on coronary arteries during cardiac arrest. While epinephrine is a potent agonist at both alpha and beta receptors, its alpha-adrenergic effects lead to systemic and coronary vasoconstriction. This vasoconstriction increases diastolic blood pressure, which is vital for improving coronary perfusion pressure, helping blood flow to the heart muscle during CPR. Remember, it's the constriction that helps pump blood to the heart. Question 30. Which medication is used to treat symptomatic bradycardia when pacing is not immediately available or effective? A. Adenosine. B. Diltiazem. C. Epinephrine infusion. D. Verapamil. Answer: C. Epinephrine infusion. This question explores the pharmacologic options for symptomatic bradycardia when primary measures fail. The phrase pacing is not immediately available or effective indicates a need for pharmacologic support for heart rate and blood pressure. Along with dopamine, epinephrine infusion is a recommended second-line agent, after atropine fails, for symptomatic bradycardia, as it increases heart rate and improves cardiac output through its chronotropic and inotropic effects. Adenosine, diltiazem, and verapamil slow the heart rate and are contraindicated in bradycardia. Question 31. What is the usual initial 4/IO dose of norepinephrine for profound hypotension not responsive to fluid resuscitation? A. 0.010 0.5 mcg/kg/min. B. 0.1-0.5 mcg/kg/min. C. 1 to 10 mcg/min. D. 2 to 20 mcg/min. Answer: B. 0.1-0.5 5 mg/kg/min. This question addresses the dosing of norepinephrine for profound hypotension. The keywords profound hypotension not responsive to fluid resuscitation point to the need for a potent vasopressor. The initial 4/IO infusion rate for norepinephrine is typically 1-0, 5 mg/kg/min, titrated to achieve the desired blood pressure. Norepinephrine is a strong alpha agonist, causing significant vasoconstriction to raise blood pressure effectively. Question 32. A patient is in cardiac arrest, and the rhythm is refractory ventricular fibrillation. After defibrillation and epinephrine, what is the next drug that should be considered? A. Atropine. B. Magnesium sulfate. C. Amiodarone. D. Adenosine. Answer: C. Amiodarone. This question describes the management of refractory ventricular fibrillation, VF, in cardiac arrest. The key terms refractory ventricular fibrillation and after defibrillation and epinephrine indicate that antiarrhythmic therapy is needed. Amiodarone is the first-line antiarrhythmic recommended for persistent or recurrent VF/private after initial interventions. Magnesium sulfate is primarily for torsades de pointes, and atropine and adenosine are for bradycardia and SVT respectively. Question 33. Which drug is an alpha-adrenergic agonist, primarily causing vasoconstriction and used to increase blood pressure in shock? A. Atropine. B. Diltiazem. C. Norepinephrine. D. Metoprolol. Answer: C. Norepinephrine. This question asks to identify a drug based on its primary mechanism of action and clinical use. The keywords alpha-adrenergic agonist, vasoconstriction, and increased blood pressure in shock perfectly describe norepinephrine. Norepinephrine is a potent vasopressor that acts predominantly on alpha-adrenergic receptors, leading to significant peripheral vasoconstriction and an increase in systemic vascular resistance, thereby raising blood pressure. Atropine, diltiazem, and metoprolol have different mechanisms and uses. Question 34. For a patient with a sustained monomorphic ventricular tachycardia with a pulse and stable hemodynamics, which drug can be considered for chemical cardioversion? A. Lidocaine. B. Adenosine. C. Verapamil. D. Diltiazem. Answer: A. Lidocaine. This question describes a specific scenario for pharmacologic cardioversion of ventricular tachycardia. The key is sustained monomorphic ventricular tachycardia with a pulse and stable hemodynamics. While amiodarone is often preferred, lidocaine is also an appropriate choice for stable monomorphic VT, as it helps suppress ventricular arrhythmias. Adenosine is for SVT, and verapamil/diltiazem are calcium channel blockers typically used for SVT or rate control of atrial fibrillation/flutter. Question 35. What is the primary reason for administering epinephrine during pulseless electrical activity, PEA? A. To suppress ectopic beats. B. To increase cerebral and coronary perfusion. C. To slow down a fast heart rate. D. To reverse the effects of calcium channel blockers. Answer: B. To increase cerebral and coronary perfusion. This question asks for the primary reason for epinephrine in PEA. The main goal of epinephrine in PEA, and indeed in all cardiac arrest rhythms, is to improve global perfusion. Its alpha-adrenergic effects cause vasoconstriction, which increases aortic diastolic blood pressure and, consequently, cerebral and coronary perfusion pressure. This action is crucial for delivering oxygen and nutrients to the heart and brain, improving the chances of achieving return of spontaneous circulation.